Each patient will have a unique presentation, will not necessarily have a full set of these features, but many other organ systems can be affected, and we'll highlight a few of those in the next few slides. Regardless of the issue of mental retardation, which is certainly the biggest problem in the CNS, several other problems can occur, including a hydrocephalus. It's usually low pressure and communicating, but it can lead to a hydrocephalic crisis. Atlantoaxial instability is a given virtually in all of these genetic cartilage syndromes. Fortunately, the number of patients with MPS II who actually have complications of cervical cord compression or myelopathy is low. It's about 5% in the literature, whereas for some of the other MPS diseases it's much higher. Seizures are more common. They're usually simple seizures that easily respond to monotherapy, but obviously controlling them is important. Sleep disturbance might be reflective of seizures, but also of obstructive sleep apnea. And behavioral problems, usually quite severe and disproportionate to the child's age, are often the first herald of mental retardation, but they can also reflect hearing loss, poor oxygenation, and poor sleep. Those issues need to be addressed before a final diagnosis of mental retardation is made. And about 2/3 of the boys, according to different references, will have some degree of mental retardation. But interestingly, 1/3 fully do not. And the correlation between severity of physical features and mental involvement is not straightforward. There are some eye signs. Unlike children with MPS I, children with MPS II do not have clouding of the cornea, but they can develop glaucoma as they get older, again disproportionate to age. They also develop a retinal dystrophy, which to an ophthalmologist looks like a salt and pepper pattern on the retina, and presents with night blindness, usually when the boys are teenagers. We've mentioned macrocephaly in the course features before. The broad nose, the flared nostrils, the prominent head, and the thick lips are the most obvious, along with the large tongue. These boys have thickened, inelastic skin. One of the most difficult things that one can do is to put an intravenous line into a boy with MPS II because the skin does not behave in the way that one usually expects for children of that age. They also develop curious pebbled skin lesions. About 3/4 of the boys, if one feels carefully over the back of the legs or the arms, the shoulders, the back, one can feel lesions, skin lesions that are often referred to as pebbles for a very good reason. They're actually pure deposits of glycosaminoglycan. As I'm going through this, recognize that I'm emphasizing unusual clusters of common signs and symptoms or individual occurrences of things that are unusual, both of which, along with the developmental view of the child, can be a key to making the diagnosis. Going back over the respiratory system again, we have upper airway obstruction, we have sleep apnea, we have the restricted lung disease, and frequent infections. Skeletal changes are more than just the craniofacial changes. They involve a degenerative hip dysplasia, which mechanistically is very like the osteoarthritis that some of us are affected with in older age, but it's occurring by the time these boys are in their teens and 20s. Kyphosis, kyphoscoliosis, and gibbous occur. Often the gibbous first presents in early childhood at less than a year of age. It's sometimes the first presenting sign of this disease, and the boys are then appropriately referred for evaluation by a pediatric orthopedist who views it as a developmental gibbous, usually reassures the physician and family that it will improve with time, and indeed it does. However, it comes back at about 2 to 3 years of age as the kyphoscoliosis if the boy actually has MPS II, and peripheral joint contractures as I've described. Be aware that cardiac disease can occur in MPS II. The boys are born with dysplastic valves. Rather like the rings of the trachea, the valves have a high gag content and they do not form normally. This will not necessarily produce anything that might be detected on routine prenatal ultrasound, and it won't necessarily produce a murmur at birth, but appropriate detailed echocardiographic scans will show the structural changes. They develop a cardiomyopathy from progressive deposition of gags as they age. But they're also at increased risk, as are many children with metabolic storage diseases, for coronary artery disease, because the excess gag gets deposited in the media of the coronary arteries, and it's not uncommon to see full-blown heart attacks in older young patients with MPS II. Likewise, they have a complex set of gastrointestinal problems. The liver and spleen enlarge as a result of the deposition of the gags. Also explains some of the gastrointestinal symptoms, including swallowing, alternating diarrhea, and constipation, essentially through an effect on small blood vessels, rather similar to similar problems in diabetics. And then peripheral nerve entrapment, the carpal tunnel syndrome, also the sensorineural component of the hearing loss can occur, again because of gag deposition in the connective tissue around critical structures like the eighth cranial nerve. Again, recognizing unusual clusters of common signs or symptoms or individual occurrences of unusual symptoms will help understand the possibility of a diagnosis here.